All right. Thanks very much, Dr. Buckley. Thank you, Sandy, and the organizing committee for inviting me. That was very good of you. In fact, I have two reasons to thank you. One was the invitation, but the other is that you used a photograph of me that's about 15 years out of date, and I really do appreciate that. It's kind of like, for those of you who are old enough to know Ann Landers, hands up, who knows what Ann Landers, you know? The masthead photograph never changed throughout her career, so I'm grateful for that, thanks. So by happy coincidence, I'm just across the street at the Westin Bristol Hotel. We're talking about omalizumab. There's an all-day meeting over there, which is a monoclonal antibody that's used as an immunomodulator to modulate mast cell function. And amongst the indications that's under discussion across the street is going to be in individuals who have various mast cell disorders, including mast cell activation syndrome. So these two meetings really do integrate very nicely together. So what I'm going to do is peel away yet another layer of this EDS onion with you. And I'm going to start talking to you a little bit about mast cell biology and how that may relate to this particular issue. So here's what a mast cell looks like. On your left, a scanning electron micrograph, and on the right, a transmission EM. And mast cells are chock full of granules. And those granules contain mediators that are the ones that are known to you that trigger allergic disease. Some of the mediators are preformed, and when a mast cell is activated, the mediators are released in those granules. They go about doing their things immediately. Some of the mediators are newly formed, and it takes a while for the synthetic apparatus of the mast cell to chug along to produce those mediators. Some of the manifestations tend to come on later. Now, we're all familiar with antihistamines, but I want to emphasize that histamine is only one of the minor mediators in mast cells. So when you're trying to block the function of mast cells and the effects of mast cell mediators, antihistamines don't go very far. They only block one specific mediator. And yet there are all these other things that are being released from mast cells. So to use one particular drug will not go very far in alleviating symptoms of mast cell disease. And sometimes you have to use a cocktail, and sometimes you have to use drugs that stabilize mast cells to prevent them from becoming activated. And that's why some of you who have problems related to mast cell disease will end up on 3, 4, 5 drugs, and sometimes even more. So here's the classic pathway of mast cell activation. This is not what we're going to see in EDS, but this is the one that we're familiar with for the most part, where somebody's sensitized to an antigen, they're exposed to this exogenous antigen, it comes along, it binds to contiguous IgE molecules on the mast cell surface, the mast cell is activated, and it releases these granules with the preformed and newly formed mediators. Now, the mediators that are released from mast cells can only do certain things. They can act on blood vessels, they can increase vascular permeability, they can cause vasodilation, they can act on smooth muscle in the gut, the uterus, the airways, the coronary arteries, and they act in a very specific way. You cannot attribute a whole bunch of other stuff to mast cell mediators because mechanistically they don't signal that way through transduction mechanisms, and there's only so many things that mast cells can do. So people would like, in some contexts, to attribute all kinds of symptoms to mast cell disease. It doesn't work. So the mediators have very specific functions, and you can see at the bottom some of the things that they do in the conventional context of allergic disease. So again, here's a mast cell full of mediators, and when the mast cell is released on the right side, those mediators are extravasated, and they act on surrounding blood vessels in wherever the mast cells happen to be. And a lot of the manifestations are really contingent on the localization of the mast cells. So if somebody's got a lot of mast cells in their gut, they're going to have predominantly gut-related symptoms. If somebody has mast cells around their airways, then of course they're going to have airway-related symptoms, or if it's around the vasculature, then it may be cardiovascular manifestations. So here are the typical types of effects when mast cells are activated. They can act on the vasculature, increase permeability, decrease peripheral vascular resistance, increase pulmonary vascular resistance, cause coronary vasoconstriction, bronchoconstriction. They can make the gut churn and cause nausea, vomiting, cramps, diarrhea. They can have delayed effects that are pro-inflammatory and ultimately lead to tissue remodeling. So when we're talking about immediate hypersensitivity reactions, and here now we're getting to nitty-gritty, this is kind of a list of the sorts of things that people will typically have when they have allergic disease. And indeed, some of the people, as you'll see, who have EDS and POTS will have these manifestations. And the question is, to what extent do these manifestations contribute to their disease burden? Is their disease mainly caused by autonomic dysfunction? Is it caused by connective tissue abnormalities? Is it caused by mast cell disorders? And to what extent do each of those contribute? And that's a very interesting question to try to tease apart. And there's not a lot in the literature yet. This is really new stuff. So first, before I get into the literature, I want to talk to you about mast cell activation diseases. There's a whole lot of them. And basically, there's one of two ways that mast cells can lead to disorders. One is that there can be too many mast cells, and that's a clonal disease when there is a mutation in a regulatory protein called the c-KIT receptor on the mast cell, and it causes increased proliferation and activation of mast cells in bone marrow. So a person's total body mast cell burden increases, and that's a bad thing. There are then mast cell diseases where the mast cells are just wonky. There aren't too many of them, but they behave in an abnormal fashion, and they release their mediators when they're not supposed to. So the World Health Organization put together a consensus classification of a whole bunch of nasty mast cell disorders. These are listed over here, and the one that perhaps most of you will be familiar with is systemic mastocytosis. And when it's primary, it happens because there's clonal proliferation of mast cells in the bone marrow, and you get some really typical findings on bone marrow biopsy and on blood and urine testing. But sometimes it happens in the context of some associated clonal hematologic non-mast cell lineage disorders like myelodysplastic syndrome. So again, I want to just mention that to have said that it's out on the table, but this is not what we're talking about. What we're talking about is something different than that. What we're talking about is mast cell activation syndrome. So we're not talking about clonality of mast cells. We're not talking about too many mast cells. We're talking about functionally abnormal mast cells in the context of EDS and POTS. So what does this look like when somebody has mast cell activation syndrome or mast cell activation disease? Well, it's a constellation. There's no one specific clinical picture. And basically, as I said, it's because mast cells are all over the body. They're distributed very widely, and the things that they do are in large measure contingent on where they live. So there's a lot of heterogeneity in what the presentations look like. They can affect virtually any organ or tissue. And the symptoms can be erratic. They are not present all the time. There are certain periods when disease flares, and there are times when it does not, when it's fairly quiescent. And it tends to be very long-lived, and it tends to wax and wane over the course of a very long period of time. So what does it look like? Well, when somebody has a mast cell activation syndrome, then they'll often, not always, but they'll often describe flushing of the skin, where it becomes bright red and hot like a sunburn. Their skin may become sporadically itchy in an unprovoked fashion. They may get spontaneous hives that, again, are unprovoked. From a cardiovascular standpoint, this is really fun because it overlaps a lot with what we've just heard from Dr. Guzman. So let's try to tease apart how much is caused by dysautonomic problems and how much is caused by mast cell disorders. So people can have abnormal episodic tachycardias. They can be hypotensive. They can feel lightheaded and presyncopal. We've heard as well that gastrointestinal complaints are really prevalent. But again, the question is, how much of that is autonomic dysfunction and how much of that is mast cell mediated? Well, one of the ways to probe is you can do a gut biopsy on colonoscopy, and these are random biopsies. And if you see mast cell aggregates, that's highly suggestive that a person has a mast cell disorder. But the other way to probe is to put them on a mast cell stabilizer that's not absorbed into the bloodstream and see if their gut symptoms settle down. And if they do, that's really good solid evidence that the gut disorder is mast cell mediated. And then, of course, when it affects the musculoskeletal system, then it can give rise to premature osteoporosis. And we do see that in the clonal mast cell disorders, not just in mast cell activation. So when that diagnosis is made, it's important to get bone densitometry with early intervention. And people can have diffuse soft tissue pain. Constitutional symptoms, we've just heard about fatigue and headache and related things. But again, part of that can be mast cell mediated, and again, that's something that we can address with certain drugs. Respiratory, obviously, if they line the airways, and then some people present with neuropsychiatric complaints related to mast cell disorders. So how do we get at that? Well, this is where it gets really interesting, because when we're dealing with clonal mast cell disorders, you do a bone marrow, there are major and minor criteria by which to make a diagnosis. But those major and minor criteria, to a very large extent, don't apply to mast cell activation syndromes. I do bone marrows. Yeah, we do them, because people often want to know. They want to have a definitive diagnosis. Do I or do I not have a mast cell disorder? But the fact of the matter is that, practically speaking, it doesn't really have an influence on therapy, because we go ahead and we treat with the same medications irrespective of what the bone marrow does or doesn't show. So in people who have mast cell activation syndrome, they don't meet the World Health Organization criteria. They usually don't have abnormal mast cell aggregates on bone spicules. They usually don't have morphologically abnormal mast cells. They usually don't have immunohistochemical staining for CD2, CD25, or CD117. They don't stain strongly for tryptase, and they don't have other relevant diagnoses. So if you rule out all that stuff, then you've ruled out something really nasty, and that's a good thing to do. So let's see. So there are major and minor criteria, as there usually are for these sorts of things. Sometimes you get focal mast cell aggregates. Most of the time you don't. What you do often get is you get symptoms. And these symptoms are validated in some publications. And when a person presents with validated symptoms, then it's really strongly suggestive of a coexistent mast cell disorder. You can go on and you can do other things, but sometimes the most helpful thing is to do blood tests and urine tests to look for products of mast cell activation. These are really expensive, and there's a lot of pushback from my institution to do these. Each panel that we do costs $1,000, and I'm worried that our institution is just going to put their foot down and say, that's it, no more of this. And what we typically do is we do at serum tryptase, we do chromogranin A, we do prostaglandin D2 in serum. In urine, we do prostaglandin D2 and N-methylhistamine. Some of those things are done in-house. Most of it is sent either to Denver or to the Mayo Clinic where it's done. And that's where it becomes very pricey. But when you get a positive urine and blood test, that's very, very helpful in making that diagnosis. So how do we treat? We treat with usually H1 and H2 blockers and with leukotriene receptor antagonist, in this case montelukast, and with mast cell stabilizers, either nalchrome, which is chromalin, or ketotifen. And there are some other treatments. Thalidomide obviously is not something that we'll reach for in most individuals because of its side effects. Levolutamide, maybe yes, although it's extraordinarily expensive. Plaquenil, in my experience, just hasn't done it. It hasn't worked at all. But I think the big comer onto the scene is omalizumab, which I think presents a lot of promise, although it's also expensive. It's about $800 per dose. And that's given once a month. So I just want to talk to you about a couple of papers that are in the literature, because there really is not very much. This is the first paper that identified a correlation between mast cell activation and in patients who have connective tissue disorders. And they looked at 9 individuals with elevated serum tryptase. This is a paper from the NIH. So these are individuals who had elevated tryptase, but as you'll see, they didn't meet the criteria for mastocytosis or any of the other clonal mast cell disorders. But not only did the index patients have elevated tryptase, but so too did their family members. And this was inherited in an autosomal dominant fashion. And the upper limit of normal for tryptase, which comes from mast cells, is 11.4. And here the mean was 21.9. And anything above 20 meets WHO criteria for mastocytosis. So this was a significant elevation. They had 33 individuals who met those criteria. Now, I'll come back to that in a second, but I want to go to this other paper from about 8 years or 9 years ago. So 170 odd patients with orthostatic intolerance, long-standing, greater than 6 months. They met the usual criteria. They didn't have any other obvious underlying causes, but they did have flushing. So the question was, well, do these individuals who have flushing have a mast cell disorder? One of the ways you can tell, as you've seen, is you can look for products of mast cell activation. And in this case, they looked for urinary N-methylhistamine, which is a metabolite of histamine. And it's excreted in stable form into the urine. So they looked at a variety of clinical characteristics. They're listed here. They looked at skin manifestations, connective tissue, GI, various types of atopy, or allergic conditions, and neuropsychiatric complaints. And what they found is that the majority of individuals in this cohort had episodic hives, which you would not see with EDS or with POTS. And they had frequent flushing episodes. GI symptoms, crampy abdominal pain, urgency, diarrhea, gastroesophageal reflux. A couple had eosinophilic esophagitis. The vast majority were atopic, which means they either had allergic rhinitis, or they had allergic asthma, or they had atopic dermatitis or eczema. So that's a very common correlate to this condition. And then chronic musculoskeletal pain and hypermobility, of course, went with this. Here are the typical triggers, and sometimes in people who have mast cell disorders, their symptoms are entirely unprovoked. So it's nice when you can identify triggers, but they're certainly not necessary. So here are the phenotypes. In those, so this is to your left, the second column to your left. In those who had elevated tryptase, the majority had associated cutaneous manifestations. The majority had a connective tissue disorder, and that was hypermobile EDS. The majority were atopic. The majority had gastrointestinal manifestations. And then the majority had neuropsychiatric complaints. Even amongst those in whom tryptase levels were normal, there were a very large proportion who had the same cluster of manifestations. None of them met the World Health Organization criteria for mastocytosis. None had mast cell aggregates on bone marrow. None had the kinds of abnormal phenotypes that we look for. And morphologically abnormal mast cells, the spindle-shaped morphology, was only in one of these patients. Most were women. So again, I'm not going to belabor this, but if you look at those who had mast cell activation or presumptive mast cell activation based on a urinary N-methylhistamine, that's the second column from your right in conjunction with POTS, you see how it differentiated from the other two cohorts. The urinary N-methylhistamine was markedly elevated, 327 micrograms per gram, whereas it was normal in the reference range for the other two groups. So with Ingrid Chung, we had a look at a cohort of individuals, and Sarah Leach in the audience was just absolutely fantastic in cracking a whip and drumming these people up from a patient support group. And these patients had POTS and hypermobility. We were looking for those who had formal diagnoses, not self-diagnosed. So we're looking for a formal diagnosis of POTS by a cardiologist, a formal diagnosis of EDS by dermatologist, including an elevated Beighton score and a diagnostic skin biopsy. And we used a questionnaire which had validated symptoms of mast cell activation syndrome. So we had a total of 63 subjects who expressed interest, 15 of whom completed the questionnaires and gave us the documentation that we were looking for. Of those 15, 12 had formal diagnoses of POTS, and of those 15, 9 had formal diagnoses of both POTS and EDS. And that left us with 9 individuals who had both POTS and EDS, of whom 67% had validated symptoms of a mast cell disorder, specifically mast cell activation syndrome. So the bottom line is that mast cell activation syndrome can co-segregate with both EDS and POTS. And there are a number of different lines of evidence to suggest that. So when somebody presents with hypermobile EDS, when somebody presents with POTS, it's appropriate to look for evidence of mast cell activation. People may have elevated serum tryptase, but in my experience in the patients that I've seen in office, and I didn't present those today, in my experience, most have normal tryptase levels. So an elevated tryptase is not commonly seen in this patient population. So more often the serum tryptase levels are normal and the diagnosis is based on validated symptoms. But importantly, the diagnosis itself would be based on the response to either receptor antagonists or mast cell stabilizers or both. So thanks very much for your attention. Appreciate it.
Any questions for Dr. Vadas? Go on.
I just wanted to make a comment on that, because it's certainly what I have seen in the clinic, and that's the reason why we both connected in the first instance, right? Because some of my patients with POTS, we identify them either with EDS or without EDS, but the ones that were refractory to treatment, the common therapies of POTS, we include the non-pharmacological and the pharmacological one, vasoconstrictors and so on, those patients, they were not improving, right? So either it was an autoimmune disease going on or some sort of allergic reaction. That's when I started to read about, the role of MCAS in this autonomy. And now the message for everybody is that we see a patient with POTS in the general practice, we have to look for these things, either EDS, either MCAS, and make sure that we refer this patient to the proper person, because it's more about awareness of the fact.
Yeah, I think your point's well taken. You know, if we're looking at a triad, and there are lots of these sorts of constellations in medicine where you see one, you have to look for the other. You know, somebody who's got nasal polyps and asthma and rhinosinusitis, you got to think about aspirin sensitivity. It's really important that we're at the stage now that if you're contemplating a diagnosis of POTS or hypermobile EDS, that I think the time has come that we also have to look for mast cell activation. Now, I'll say in the same breath that right now our testing is not that fantastic, because we get a lot of false negatives on testing for serum and urinary markers of mast cell activation. So sometimes you have to use a clinical trial of therapy, and even then our drugs are not fantastic, and some of them are very expensive and some of them may not be that well tolerated. But we do have now in the offing the prospect of using Xolair or omalizumab as a biologic to treat mast cell disorders, and that's something that we'll probably see within the year coming up.
So thank you very much. A late question, because I've sent some of my patients to you, but I want to know which are your minimum criteria for sending, because if we send all patients with EDS and allergic symptoms, and honestly, I asked in sick kids if I could send them locally, and they told me I would send them to here. That's a Michael's. We will overwhelm you. So what would you establish as your minimum criteria by which we should send them for exclusion of mast cell activation?
That's such, you know, this meeting is good fun because now I'm putting faces to names of people that are in the field, and I haven't met you guys in person before, so it's great. You know, that's a really tough question because you know, you're not going to be able to do the screening tests. It would be great if you could, but St. Mike's right now is the only center that offers to do the screening tests and send them down to the States. So, you know, the best I can offer you is if you look at validated symptoms and they come up as positive, then you've done a bit of a preliminary screen and I can have a look at them. But beyond that, I wish there were another screening test that I could offer you that you could do initially, which would give you you know, something of a yes-no stratification, but that doesn't exist yet.
Last question, honors.
There's been some literature on eosinophilic esophagitis in the overlap with connective tissues and mast cell activation, and that's a disorder with either non-IgE-mediated allergic reactions or IgE-mediated. Do you have any comment about the importance of foods and specifically the non-IgE-mediated reactions to foods in this mast cell activation process?
Yeah, thanks for that question. So I noticed that you mentioned food allergies and you mentioned delayed type hypersensitivity reactions to milk protein. And in the allergy world that I come from, we don't see much of that. So basically here, but I'll be specific about that. In very young kids, we see milk-induced food protein-induced enterocolitis syndrome, which is a nasty, nasty condition. That's easy to recognize most of the time. That's not what we're dealing with. Eosinophilic esophagitis in adults is interesting in that about 80% of people with EOE will have a specific food trigger, and it's typically one of 6 foods. And if you put them on an empiric 6-food elimination diet, then 80% of them will no longer have eosinophilic inflammation, and it'll be histologically resolved. So it's very clear that in EOE, about 80% have a food trigger. But we don't yet have a feel for whether that's part of this syndrome, and if so, how it relates. What is clear is that there is a general atopic predisposition in this patient population. As you saw, almost 100% of patients have some degree of atopy. So whether it's causal or whether there's just whether it's an epiphenomenon, we just don't know yet.
Thank you very much, Dr.